हेलो 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 हेलो
बोलना भी नहीं मानती हूँ मैं।
हेलो 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 ज्योत्सना, आवाज आ रही है?
हाँ मैम आ रही है।
अच्छा, तुम्हारी भी बहुत अच्छी आ रही है। तो अनदर 10 मिनट्स, तब तक ब्रिजेश हो जाएगा, पेशेंट बाहर भी आ जाएगी। ठीक है,
ओके मैम।
हेलो, लंच लेके कोई गया? कितने बजे?
Doc,
Good afternoon.
Good afternoon.
good afternoon. Good afternoon.
Chalo, we can start whenever Jyotsna is ready, and I think everyone else can mute themselves. Only the speaker should keep herself unmute. All the best.
Thank you, ma'am.
हम भी गुड आफ्टरनून बोलेंगे ज्योत्सना को. गुड आफ्टरनून ज्योत्सना.
Hello, ma'am.
Just wait for a few seconds. Brajesh is also going to join us. Ajit आगे Brajesh wait now.
कित्थों है ब्रजेश?
बस यही है, मेरे साथ ही है. He had a difficult case actually.
अच्छा.
Just 1-2 minutes, that's all.
Yes, ma'am.
Join? Okay.
Fine.
Okay, good afternoon, everyone.
Good afternoon, ma'am.
Good afternoon.
So,
Good afternoon. Looking forward to this nice topic.
Yes. So pregnancy as such is a physiological state, but during pregnancy, lot of things happen which makes it pathological, and one of the problems in pregnancy, which is not very common, but we do see such cases, and we should know how to manage it. And one of such situation is chickenpox in pregnancy, because pregnancy is an immunocompromised state. So pregnant women are more prone to have such infections. And if a lady who is not previously had chickenpox, or someone is going to planning for pregnancy, so all these things will be covered by Dr. Jyotsna. And I must tell you that Dr. Jyotsna is youngest among all of us. She's senior resident in Obs and Gynae, and she's going to tell us about chickenpox in pregnancy in a very, I should say, concise manner. So, Jyotsna, over to you. You can start.
Thank you, ma'am. Good afternoon to all my teachers. I'm going to share my views on chickenpox in pregnancy. Now, first of all, we should know what is chickenpox. It is also known as varicella, and it is a highly contagious illness that presents as a itchy rash, and which is followed by a vesicular eruption on the skin. The eruptions basically look like a dewdrop on a rose petal appearance. It spreads by direct contact, that is via respiratory droplets or secretions. The incubation period is around 1 to 3 weeks. Now, after knowing what is chickenpox, what causes chickenpox? It is mainly a DNA virus known as Varicella zoster virus, which is a member of herpes virus group of that is SHV3. The primary infection of this virus causes chickenpox, but sometimes it goes latent in the sensory dorsal root ganglion, which may manifest afterwards when the person is immunocompromised. That results in shingles. The humans are the only known reservoir of this virus. For how long is the disease contagious? It is most infectious 48 hours before the rash appears, and it continues to be infectious until the last vesicles crust over. This usually takes around 1 week, around 6 to 10 days from the beginning to end. The point to note here is that the scabs which are formed, they are not infectious. Now coming to our topic, chickenpox and pregnancy, why are so we concerned about this? First of all, the primary varicella zoster virus infection is uncommon in pregnancy. This is because most of us, 90% of the population are seropositive. That is, they had a history of chickenpox in their childhood. Most of the infections of chickenpox occurs in less than 14 years of age. But the chickenpox in pregnancy, the incidence is around 3 in every 1,000 pregnancies. So the diagnosis of varicella in mother is basically on the clinical findings alone, which manifest as a typical skin eruption. The lesion began as a red papule. The most common site of is face, throat. The distribution of the lesion is centripetal, that is, they grow from center to periphery. Then they progress to clear vesicles, then to cloudy pustules, and finally a dry crusted lesion is there. The systemic manifestations include malaise, fatigue, fever, tachypnea and dyspnea, which may be a symptom of underlying pneumonia, superimposed bacterial infection, headache and photophobia. They may be symptoms of underlying encephalitis. Now, whenever there is a doubt of the diagnosis, we can do a swab. We can take a swab vesicle for varicella zoster virus PCR, or we can do a varicella zoster serology to confirm the diagnosis. Chickenpox in pregnancy has both maternal and fetal risk. The maternal risk is around 5 times. The mother has a 5 times greater morbidity than a non-pregnant patient. So this is the reason why we are so much concerned about this disease in pregnancy. The most common complication is a varicella pneumonia, which is around 20% with high mortality of 15%. The others include encephalitis, myocarditis, hepatitis, glomerulonephritis, and thrombocytopenia. And the severity of all these complications increases as the gestation period advances. Now, coming to risk to fetus, the risk to fetus depends at what time of gestation the period of at what time is the infection occurring in pregnancy. There's an organization called as Organization for Teratology Information Service. It's a European organization which studies the effect of medicines and infections, teratological effect of medicines and infections on fetus. And it is a most reliable organization on evidence-based medicine. According to this Otis organization, if the infection occurs in first trimester, then the risk to fetus is around 0.5 to 1%. If it occurs within 5 days before delivery and 2 days after delivery, it is around 25 to 30%. And if it occurs between 13 to 20 weeks, the risk is about 2%. Now, if the infection occurs at 13 to 20 weeks, there's a syndrome called as congenital or fetal varicella syndrome. And if the infection occurs near term, then there are chances of neonatal varicella. Now, first of all, we'll study about congenital varicella syndrome. This results from transplacental infection during pregnancy, around 13 to 20 weeks of gestation. And the risk is small, that we have already seen around 2%. The diagnosis of congenital infection is mainly done by ultrasound examination. The features included are intrauterine growth restriction, microcephaly, ventriculomegaly, presence of echogenic foci in the fetal liver, circular scarring, and lymph deformity. As we can see in these pictures, we can see lymph deformity and circular cicatrization around the lymph. Then neonatal varicella occurs when maternal infection occurs near term. If infection occurs 1 to 4 weeks before delivery, there are 50% chances of a fetus to get affected, and 23% of these 50% develop clinical varicella. There's a high risk for disseminated varicella. Mortality rates are as high as 30%, but the prognosis is much better if the lesions develop greater than 5 days after delivery, because the antibodies are transmitted across placenta from the mother to the fetus. The manifestation is a disseminated mucocutaneous infection, visceral infection, and pneumonia, more like an adult. Now, prevention of neonatal varicella can be done by isolation of the newborn and treat immediately with varicella zoster immunoglobulin or antiviral therapy. The woman, the mother, should be made aware of a few things, that is the potential adverse maternal and fetal sequelae, the risk of transmission to her fetus, and the options which are available for prenatal diagnosis. We should reassure her that the risk of spontaneous miscarriage is not increased if the chickenpox occurs in the first trimester. Now, what should a woman do if she develops a rash in pregnancy? She should report to the doctor immediately, should avoid contact with the susceptible individuals. She should receive oral acyclovir if they come within 24 hours of onset of rash and is more than 20 weeks of pregnancy. Acyclovir therapy in less than 20 weeks of pregnancy can be given because acyclovir is safe. No trials have been seen to see the teratogenic effect of acyclovir on fetus, but it should be done with caution, looking the benefit risk ratio of mother and fetus both. And she should maintain hygiene to prevent secondary bacterial infection. The acyclovir therapy dose is 800 milligram thrice a day for 7 days. Valcyclovir can also be given 1 gram 3 times a day for 5 to 7 days. As I've already said, that there has been no adverse fetal or neonatal effects seen. And the one point to remember is that acyclovir is not recommended for post-exposure prophylaxis. That is, after the rashes appear or after the rashes appear, acyclovir has not been seen to prevent fetal infection. Now, symptomatic treatment include antihistaminic and calamine lotion to stop the itching. Aspirin should be avoided because of risk of Rash syndrome. Acetaminophen can be given. One point important is to note is that the mother should not scratch the lesion, and the best way to stop scratching is to keep fingers and nail short. Now, when to report to a hospital? A woman should report to a hospital if fever rises above 102 degrees Fahrenheit, lesions become very red, warm, tender, and there is pus leaking out from them. She develops lethargy, she has difficulty in walking, stiff neck, which all shows the features of encephalitis, severe vomiting, and difficulty in breathing and cough, as in case of pneumonia. Now, what are the complications which we are worried about? These are pneumonia, neurological complication, hemorrhagic rash or bleeding, dense rash with mucosal lesions, and in immunosuppressed or woman taking corticosteroids for about 3 months, there are indications for hospitalization. Complicated chickenpox in pregnancy, what is seen that there is a high risk of varicella of the newborn with significant mortality and morbidity if the infant is born within 7 days of onset of maternal rash, or a mother develop rash up to 7 days after delivery. In such cases, in complicated cases, IV acyclovir is recommended about 10 to 15 milligram per kg body weight every 8 hourly. Now, if maternal infection occurs at term, then we should possibly delay the delivery by 5 days after the onset of illness. This is because so that the antibodies are transferred to the fetus transplacentally. If delivery occurs within 5 days of infection, then make sure to give varicella zoster immunoglobulin to the neonate. Varicella zoster immunoglobulin does not prevent neonatal infection, but it reduces the mortality rate and morbidity also. Then monitor the baby for the signs of infection for around 14 to 15 days. If neonatal infection occurs, then it should be treated with acyclovir. Now, prenatal diagnosis of varicella zoster is difficult and invasive. The benefit risk ratio is also low. The non-invasive method is with ultrasound, and we should look for the features of cranial calcification, forencephalic cyst, hepatic calcification, echogenic bowel, ascites, hydrops, and polyhydramnios. The invasive method includes amniocentesis, which is not routinely advised, because amniocentesis has a poor positive predictive value. That is, if amniocentesis comes out to be positive, that does not mainly indicate that the fetus is going to have a fetal varicella syndrome. Now, timing and mode of delivery should be individualized for every mother. During the varemic period, delivery should not be there, because mother has a risk of bleeding, thrombocytopenia, DIC, and hepatitis. And there is also a high risk of neonatal varicella in fetus. Now, if delivery occurs by cesarean section, what is the optimum mode of anesthesia? Epidural is safe because in that dura is not punctured, and any site free of cutaneous lesion should be chosen. In spinal anesthesia, there is always a risk of transmitting virus from skin to central nervous system. And in general anesthesia, it may exacerbate lesion, and also in case of underlying pneumonia, general anesthesia is dangerous. Now, pregnant woman with a history of contact with chickenpox, if she comes to us, the first thing we'll do is to take a definite past history of chickenpox. If she has a definite past history, then reassure her that that her baby is of no risk. But if she is not immune and has a significant contact means that she has the contact with this in the same room for around 15 minutes, or there is a face-to-face contact for around 5 minutes. Then give varicella zoster immunoglobulin as soon as possible. Now, varicella zoster immunoglobulin is best recommended within 96 hours of exposure of a pregnant woman. But if she comes after 96 hours, then it is not that we don't have to give it. We can give it up to 10 days. It is effective when given up to 10 days after contact. A second dose may be required if there is a further exposure, or 3 weeks have elapsed since the last dose, because the half-life of immunoglobulin is around 3 weeks. It is also recommended if it is not possible to obtain an antibody titer within the 96 hours, so it is better to give prophylactic VZ immunoglobulin. Now, what are the indications of varicella zoster immunoglobulin? First of all, it should be given in a susceptible pregnant woman. In newborns, if a newborn is born to a mother who develops a rash between 5 days and before the delivery and 2 days after, then the newborn should be given 125 unit dose of prophylactic varicella zoster immunoglobulin. This is the minimal dose which should be given. It can be given up to the dose is about 125 unit per 10 kg body weight. It is given like that, and a maximum of around 625 unit can be given. Now, in neonates born less than 28 weeks or less than 1000 gram, these are those newborns. If they are immunocompromised, and if they are exposed, then regardless of the maternal history, VZISD should be given. Similarly, newborns who require intensive care or who are immunocompromised, they should also be given regardless of the immune status or gestational age. Now, varicella prevention. Adults who have no history of chickenpox or who have never been immunized against the disease, they should receive the vaccine. All non-immune or seronegative women should receive vaccine before pregnancy or even in the postpartum period. And if they are planning for the pregnancy, they should at least avoid pregnancy for 4 weeks, that is 1 month. But suppose if exposure to varicella vaccine occurs in pregnancy, then it is not an indication for termination of pregnancy, because the risk, theoretical risk to the fetus is seen very small. Now, vaccination is safe during lactation period, so postpartum vaccination is always advised to the female. Now, the dose of varicella vaccine, 2 doses are given 4 weeks apart. The first is given around 12 to 15 months in baby, and second at 4 to 6 years. 96 to 100% of seroconversion is seen between 4 to 6 weeks post-vaccination, and the antibody titer is more than 90% even after 20 years. Now, summarizing what we have seen in last 15 minutes is whenever there is exposure to varicella in a pregnant woman, we should take the well-documented history of the exposure. If she has a well-documented history, reassure her that neither she nor her baby is at risk. But suppose if there is no documentation of natural infection, then obtain the IgG serology. If it is positive, reassure the patient that there is no risk. But if it is negative, Then administer prophylactically varicella zoster immunoglobulin or within 96 hours preferably, or it can be given up to 10 days, or we can give acyclovir or valcyclovir. If mother does not develop infection, it is well and good. But if she develops acute varicella, if it is mild, treat with acyclovir or valcyclovir. But if it is severe, give intravenous acyclovir and then evaluate the baby with ultrasound for signs of infection. Thank you so much.
Thank you so much, Jyotsna. Now, Dr. Pyali can comment up on the congenital varicella syndrome, whatever she has told us, and congenital infection of newborn.
Yeah. So at first, Jyotsna, I must congratulate you. You have covered everything almost very, very nicely.
Thank you, ma'am.
So she's covered most of the part. One or two things that I would like to add to this. Number one is that VZIG, the dose depends upon the newborn, the weight of the newborn. Whether it is less than 2 kgs, that's our marker as we give, or it is greater than 2 kgs. For infants who are less than 2 kgs, we give 125 units. But for those infants who are greater than 2 kgs, we give directly 250 units. One thing. Another thing is, if the infection occurs early, as Jyotsna was telling, there's ample time for development of antibodies, and usually only 1% are affected also, very few. But if it is day 5 prior to day 2 after delivery, that the very perinatal period when the mother develops, then we have a lot of problems, and we should not let such people go home before 3 days, even if the child does not show any symptoms by immediately early. So remember that you have to give such a child IV varicella immunoglobulin. But the problem is, many a time we do not get varicella immunoglobulin. In such a case, we will have to give IVIG, and IVIG 400 milligram per kg as soon as possible. So this is between 48 hours to 96 hours, as she has been saying. We must give some kind of immunoglobulin to the baby, and thereafter watch within 3 days. And from 7th day of the onset of rash in the mother, you can start off with 30 milligram per kg of intravenous acyclovir. Sometimes the child cannot be given, or a peripheral vein is not there. At that point of time, even oral acyclovir can be given, but the doses are higher. From 30, you go to 80 milligram per kg. And as I said, that used to be very fatal, but now no more with the advent of immunoglobulins and acyclovir. Most of the children are, the case fatality has become very, very low. So that is all I wanted to add. Thank you, Jyotsna, for covering so well again.
Thank you, ma'am.
Dr. Pyali, this varicella zoster immunoglobulins, there's the issue with availability and the cost also.
Yes, both of them.
Is it costly?
Yes, it is very costly.
Okay. So, so once a baby is born to from either neonatal infection or congenital varicella syndrome, so such baby, just I wanted to know the prognosis. Is such babies are doing well if properly, timely given the immunoglobulins and acyclovir? So long-term consequences are how it is?
Prognostic. Jyotsna, would you like to take that question?
Ma'am, you can take the expert.
Okay. Prognostically, Anju, that they don't do badly. You know, we follow them up for at least 3 weeks time, give them that IVIG and then 10 days of acyclovir. Most of them do well. But of course, there is a problem of the encephalitic syndrome. where of course the blood-brain barrier, you remember, is not very well developed in neonates. So there is this problem where you might have to land, but that's very few. The case fatality is very little, and prognostically most of them do very well. 1 or 2% cases you'll find that they'll end up with encephalitic syndrome.
Okay. Okay, Dr. Pelly, thank you so much for taking up these queries and showing your, experiences, sharing your experiences with us. Ajit,
I
would you
want to
like
say
to
something.
say, yes?
First of all, thank you, Jyotsna, for a really nice presentation, a very important topic which physicians, dermatologists, pediatricians, neonatologists, and gynecologists, all of us face. It's a overlap topic. And as a physician, I'm forever asked about the vaccination also. So this is a very important topic. Now, what I wanted to know from Jyotsna, you is acyclovir and valacyclovir, between the two of them, giving in pregnancy, in the safety profile, is there any difference? I know that Ajit prefers giving valacyclovir to non-pregnant people, all the adults who can afford, because valacyclovir is 3 times a day. acyclovir दुनिया में इकलौती दवाई है जो दिन में 5 बार दी जाती है 800 मिलीग्राम, तो आधे से ज्यादा लोग तो खाते नहीं है और उसको हमेशा आके बताते हैं कि मैडम आपने गलत लिख दिया था, 5 बार लिख दिया था, तो मैं समझ गया था आपने गलत लिखा है, मैंने 3 बार खाया, 4 बार खाया, 2 बार खाया, तो बार बार समझाना पड़ता है. So that is fine. In a non-pregnant person, we can still deal with it. So, and valacyclovir is the alternative. So now in pregnancy, between the two of them, is there a difference in the safety profile that I would prefer one upon the other, or are they equivalent?
Safety profile of both the are same. Matlab, there has been no teratogenic effect seen, or you can say that the studies are lacking on seeing the birth congenital defects of both the medicine. But whatever studies have been done, they have shown that there is no major birth effects seen in fetus on giving acyclovir or valcyclovir, both.
All right. And one more thing, the Teratology Society of Europe that you talked about. So are we able to correspond to them? Are we able to, I'm just asking you, you may or may not know. So are we able to send them emails and ask questions and then they reply as to whether a particular drug or something we can use in pregnancy, or it's not like that? They have everything on their website. And can you share that website with us on
Yes,
GH
ma'am, I can
webinar?
share you a website. I have gone through that, but
Yeah.
I don't know whether they reply to mail or not.
Okay. Thank you. That's a good reply. That's fine.
Jyotsna, is there this acyclovir and valacyclovir recommendation is for what? Is for acyclovir or is for both? The recommendation for and this antiviral in pregnancy is only.
Recommendation is, ma'am, acyclovir.
Only acyclovir.
But valcyclovir can also be given, and now even famcyclovir is also people are recommending both
During pregnancy.
Yes, ma'am.
Okay. Ajit, you'd like to give your comment?
I prefer acyclovir when I realize that the patient will be compliant. Otherwise, valacyclovir, as Dr. Prerna highlighted, good thing is that with pregnant lady, the compliance becomes slightly better. We can stay and stick to acyclovir because that has been used more often without any serious side effects. We as yet don't know about valacyclovir. It has not been used that frequently. Another important thing I'll request all of you to, Dr. Piali, to highlight, what about the interval between the 2 doses? Is it the same as the adults or the children or the newborns between the 2 doses of the vaccine?
The vaccine? Yes, we give, no, for the children, we give one at around 18 months, another at 4 years.
That means the interval is around 3 years, 4 years.
Booster, along with the first booster, and then again after with the second booster.
That means the interval is around 4 years.
Correct.
But in adults, we give at an interval of 4 weeks.
4 weeks, yeah.
Ajit, if there is a hurry, you can give it within 4 weeks. I mean, at 4 weeks. But if there's no hurry, it is always better to follow the childhood immunization schedule and boost in 4 years.
No, that I understand that, but more or less it is understood that in children the schedule has to be followed as you described just now.
One with
But
first booster, one with second booster.
But amongst the adults, when it is required, generally it is required with a purpose. So we can cut it down to 4 weeks.
Yes.
Ajit, 4 weeks
Thank
is the
you.
minimum interval. You can give after that also.
Yes. Even in children, Ajit, if they have to travel abroad, if they have to go away or something of that kind, we cut it short. We can give a second dose after 4 weeks as well.
Yes.
But adults में कुछ ऐसा है ना कि people who are born after a certain year and they have received one vaccine, they should now receive a booster or 2 more doses. And travel के लिए all the kids
that depends on the seronegativity of the patient, Prerna.
Yeah.
If they have received one or they are unsure of their disease status, then they get a seronegativity done, and if they are negative, receive full doses.
Older version of varicella vaccine, the company was not sure when to give the booster. So initially when it came, they said that for adults it's a single dose thing, but they were unsure. So they said that it may be repeated after 10 years. But all that has now been cut down and it is now well defined.
10
It
years
is 4 weeks. बहुत पहले था मैम, शुरू में सिंगल डोज का ही आया था इसका adults के लिए, और 10 years वाला वो लोग कहते थे till 10 years it will cover, after that they don't know.
Ajit, just this is my query, that is there any relation between the lesions, if it is more dense, then the patient is going to have more complication, or less lesion, less complication? Is there a relation between the skin lesion and the maternal complication?
I have not come across any literature as such, but per se, chickenpox in seronegative adults is usually in the severe form. So we always anticipate complications or a duration of a longer duration.
No, Ajit, say it again.
लिटरेचर में कहीं ऐसा मिला नहीं है मैम, लेकिन ये जरूर होता है कि because whenever chickenpox is in adults, it is a bit more severe and it has more complications, morbidity, not mortality. So we can presume that the adult form will be a severe form. That is why we straight away go for Acyclovir.
ज्योत्सना कुछ बोल रही है.
Yes, ma'am. उसपे बस मैंने जो पढ़ा था उसमें ये था कि whenever the lesions are more than 500, then it usually takes a severe form. And in pregnant patients, if it is more than 100, then there is an indication कि आप you can look for complicated chickenpox in pregnancy. Yes, ma'am.
That's a good tip. लेकिन 100 को तो गिन सकते हैं, 500 लीजन्स कोई गिनेगा नहीं एडल्ट में.
500 वाला इम्यूनो कॉम्प्रोमाइज्ड होता है.
हाँ.
500
वाले में भी एम्ब्रायोपैथी के चांसेस होते हैं अगर अर्ली होता है.
Yeah, so that's what, like 100 is something you can count. But किसी की chickenpox lesions बैठ के उसके शरीर पे ना मरीज काउंट करने वाला है ना डॉक्टर, तो 500 वाला अपन छोड़ देते हैं.
That happens only in severely immunocompromised patients. It's not a usual thing.
No, but pregnant lady, they are very prone for pneumonia. That's why I'm asking.
100 is a good, like it's a good tip, Jyotsna.
And is okay. Not only mother is prone for pneumonia, mother is also prone for preterm deliveries. और अगर preterm deliveries होते हैं तो उसको treat them just like they have actually neonatal herpes, and उनको फिर पूरा देना है, पूरा पैराफर्नेलिया, मतलब IVIG भी देना है, 3 दिन दे के Acyclovir भी देना है, पूरा करना है if it's a preterm.
Yes, there is risk of preterm, risk of intrauterine growth restrictions. The anomalies what she already elaborated. So that is all about. Anybody has any questions, any query? Shalini, Niru?
Shalini, unmute karo.
It was a very good presentation, Jyotsna. सब कुछ crystal clear, everything very clear. कुछ नहीं पूछना तुमसे.
Thank you, ma'am.
Jyotsna, can you share the last slide on the webinar group? जो summing up वाली थी?
Prerna, is there any age limit for giving chickenpox vaccine? No.
I don't think so. I don't
कभी
think
भी
so.
दे सकते हो बस सीरो नेगेटिव टेस्ट
Zero
करके.
negative. Yeah.
टेस्ट कभी नहीं करते हम लोग सीरो नेगेटिव. हमारे यहाँ तो अवेलेबल नहीं है एंटीबॉडी.
हाँ करते तो कभी नहीं. One does not.
We only
कभी
go
हुआ
by
नहीं.
the
You can give it.
We go by the history कि पेशेंट को हो चुका है कि नहीं. चिकन पॉक्स यूजुअली मरीज को अच्छे से याद होता है या उसके पेरेंट्स को याद होता है. सो वी गो बाय. हाँ, IgG तो हमारे यहाँ करते नहीं है चिकन पॉक्स की. All the people who are going abroad, they need the serology, so they get it done from Lal Lab and all, not from SGPGI. हमारे यहाँ नहीं होता.
ठीक. एक ज्योत्सना से सवाल है कि if at term patient goes into labor and मान लो बहुत early में चिकन पॉक्स हुआ है, is there an indication for doing a cesarean rather than leaving for vaginal delivery?
No, ma'am. Chickenpox is not an indication for cesarean section.
अच्छा. Even in the, हाँ early उसमें भी कोई indication नहीं है.
No, ma'am. No, ma'am.
In fact, it is contraindicated. It is contraindicated. हम लेबर को बढ़ाने की कोशिश करते हैं rather than.
नहीं अगर लेबर में चली गई है. अगर लेबर में चली गई तो.
नहीं मैम, it's not an indication. ये basically cesarean section herpes में होता है मैम. Genital herpes में इसमें नहीं होता.
Genital herpes में because passing through the birth canal is going to give HSV.
Infectious.
That's
इसमें तो आपके मदर के वेसिकल्स से भी आ सकते हैं बाद में भी ना. तो आप
बाद में भी आ सकते हैं.
बचा नहीं लोगे उसको.
जी मैम.
हाँ.
नहीं आइसोलेट नहीं करना है. आइसोलेट नहीं करना है. किसी ने बोला आइसोलेट करने को. मैंने कहा आइसोलेट नहीं
आइसोलेट तो नहीं करना है बेबी को. हाँ. चलो.
Rajesh, ready for the last slide? Last slide, Jyotsna share कर लो.
कैसे आएगी मैम?
उसमें स्क्रीनशॉट ले लो अपने लास्ट स्लाइड का और उसको वेबिनार ग्रुप में पोस्ट कर दो.
अच्छा, ओके मैम.
ठीक है, that will be good. Please do that because that was a very good summing up.
लैपटॉप में प्रिंट स्क्रीन दबा दो, वो आ जाएगा तुम्हारा और उसी को शेयर कर देना.
अपना फोन ही दिखा देगी. दिख जाएगा.
शेयर कर लेना.
ये स्लाइड शेयर कर.
अपना फोन दिखा दे तो दिख जाएगा.
या फिर पूरा स्क्रीन शेयर कर लेना, उसके बाद सेलेक्ट कर लेना.
डेस्कटॉप उसमें पीपीटी में.
डॉक्टर ज्योत्सना कैन शेयर द स्क्रीन स्लाइड.
लास्ट स्लाइड, इसकी लास्ट स्लाइड.
अब तुम स्क्रॉल करके लास्ट पे चले जाओ.
जी मैम.
स्लाइड को क्लिप कर लेते हैं. फिर मैं कर देती हूँ, क्लिप करके एंड पोस्ट कर दूंगी.
कर दिया मैम.
1 मिनट लगाए रखो ताकि हम फोटो ले लें. Okay, thank you, Jyotsna. That's a real ready reckoner. So thank you for that.
Acyclovir के indications तुमने बताया all complicated और सिर्फ pneumonia और encephalitis.
Ma'am, all complicated. All complicated.
But in adults, we give to everyone as long as they come to us within 48 hours or so of starting with the rash, and we have the clinical diagnosis.
उसकी severity भी कम हो जाती है ना.
In adults, we start with it unless they come really late. Then we won't give because सबको फायदा नहीं है. But otherwise we give to everyone.
माने even if they are coming to us with an contact with any other individual who has had chicken pox.
No. Are we giving that? Aji, are we giving that?
Yes, we are. Supposing प्रेरणा को है और मैं प्रेग्नेंट हूँ और मेरी प्रेरणा से कांटेक्ट हुई है and I come to you, you can give me a vaccine.
Okay.
Yes.
I thought that Jyotsna said कि नहीं.
Significant नहीं मैम. Contact should be a significant contact.
नहीं. Suppose significant contact है. I thought you said कि post exposure prophylaxis pregnancy में नहीं करते हैं.
We also see for susceptibility of the मतलब patient. Susceptible अगर है.
susceptibility है और significant contact है तो post exposure prophylaxis करते हैं. I thought तुमने कहा था एक slide में.
We go for immunoglobulin, ma'am.
We go for immunoglobulin. हाँ, we go for immunoglobulin, not acyclovir.
Not acyclovir.
Acyclovir नहीं बात कर रहे. हाँ, immunoglobulin दे देंगे.
Yeah, that's what I
And
was
that
saying.
too within this first 7 days of contact. उसके बाद नहीं.
That I agree with. PEP नहीं, हम PEP में हम acyclovir नहीं देते.
अच्छा डॉक्टर
immunoglobulin भी
ज्योत्सना
अगर Dr. Pyali, if she is sure that she had chickenpox vaccination, then even then should we give her pregnant?
No,
No, ma'am.
96%
There is no
Then
such
we won't be giving
this
them.
thing. There is no such
If she is
this
not
thing.
sure of her vaccination, then you can give the immunoglobulins post-exposure. Otherwise, no. So let's.
Dr. Jyotsna? Yeah, on what basis do we decide whether we have to go for acyclovir or valcyclovir?
Most important, most
Patient
common question.
science.
Ajit and I discuss this all the time for all non-pregnant adults.
As ma'am has already said, sir has also said that acyclovir is convenient to give. So, and in pregnancy, we prefer, we can give both, but the recommendation is for acyclovir. So
Okay, I think the advantage of acyclovir or valcyclovir is only that it is having fewer daily dosing. The only advantage.
Yeah.
Convenience. Okay, I think everybody is done. Rajesh?
Rajesh ji.
Okay, Rajesh is here only.
Rajesh, अभी फोन उठा लियो जब करूं तो डीन साहब का फोन आ रहा था अभी तो मैं फीडबैक देती हूँ तुमको.
Okay, let's wind it up.
Thank you, Jyotsna. Thank you, Anju.
Thank
you, Dr. Pyali.
Thank you.
As she is the youngest, she has presented the latest. So thank you, Jyotsna.
Yes, very nice presentation.
Very nice.
Thank you, ma'am. Thank you, sir.
Okay. Thank you and bye everyone for the next
Bye,
webinar.
ma'am.